Good afternoon. Raja and I have been talking about AI in healthcare for a good chunk of time. We haven't caught up in a while, and we realized that this would be a good opportunity to find out what he's working on, what I'm working on, in front of you. So, so we sort of know what we're going to talk about each other, but not that much. But all interactions we had in the past were we were on the same page, but sometimes we had contradictory views of things. So, Richard had a great presentation on AI and the impact of AI. We are inundated with conversations about GPT and what GPT can do and what will it do and all of that. And there's a chart that I want to share. That's like, to me, this is a mind-boggling view of what's happening today in industry. GPT-4. So this is a XY diagram of knowledge tests and the performance of large language models on knowledge tests. And about 95% is expert humans. So you're all expert humans in your domains. There are MDs and artists and finance people. Expert human knowledge is in the 90s. Raja's mom and my mom are in the audience. They happen to be in the 100%. Everybody else is in the 90s. GPT-4, so the two mind-boggling facts are, A, GPT-4 is very, very close to expert human knowledge. Second, even more mind-boggling fact is that it took very, very little time, a couple of years, to go from GPT-3 at about 50% to GPT-4 at about 95%. So then the question becomes, ask not what GPT-4 can do for you, ask what GPT-5 can do for you, or GPT-6 or GPT-7. So we are at the beginning of a revolution that we are going to take advantage of as a human race for a very long time. I liken this this is like the internet, but the internet was actually started in 1969. I wasn't born at the time. But in the mid-90s is where the revolution happened, and that's because Netscape came along. And with Netscape, the internet became available, it became democratized to everybody. We are at a moment now where AI is becoming democratized for everybody. So why does it matter? Why does it matter in healthcare? This is not a hammer, let's find a nail. We have problems as humanity that we need to address. This is the big one. There's going to be a global shortage of 18 million healthcare workers. We have no way we cannot educate enough healthcare workers, we cannot produce enough healthcare workers to tackle that. So AI is becoming a must in certain domains. What do you think?
So
do you agree?
I agree. So what I think is that this is a worrisome number. But on the day-to-day of what I do, what I want to share with you, Jean-Claude, first of all, good to see you.
Yeah, I know.
And then is what's behind it. And so, what's healthcare? Healthcare takes you from ach, or ouch, to hey, which is this word that you can't translate in English unless somebody has, and it's not brother. So the healthcare system, again, we start with a complaint, something that brings you to your clinician and to the healthcare system. Put yourself in that mindset. The first thing you need to do is access the clinic, and then there's this whole bunch of stuff that happens on PowerPoint, but fundamentally, you see your clinician. Today it could be a doctor, it could be a nurse practitioner, physician assistant, and then the clinician thinks. This is what my interest is. It's clinical reasoning, is how doctors think. And then the clinician thinks, okay, I think you have a problem, I think I know what it is. And then there is the communication of this problem to the patient, to their colleagues, to the healthcare system, to the pharmacist, so that everything gets streamlined, you get your prescription, and then you have your khay at the end. However, this system is not working well. There's difficulty accessing. I mean, how many times, so I'm a clinician, I work at Massachusetts' greatest hospital, which is Brigham. And then, and even for me, when I have a problem, it's hard for me to access a clinician. And so you can imagine how hard it is for somebody who does not have that kind of luxury and causing inequity. My area of interest is clinical reasoning and how doctors think. So, we go through medical school where we're supposed to memorize all these textbooks, and the amount of information is actually doubling every 7 months. There's a lot of biases. We get tired, so on and so forth. And so I'm going to give you an example. This was COVID time. I was running in the intensive care unit with the team. So, I was the attending. There was a fellow from, a Harvard graduate, a Hopkins resident, 10 students from all over the country. So the best of the best. I'm from AUB, a graduate representing. And then, so we spent, thank you. So we spent 30 minutes talking about this patient who's very, very, very sick, who had a fever. We're thinking, we think it's either COVID or an infection. Do we start antibiotics or not? After really thinking deeply, looking at all the information, we decided not to give antibiotics. The second day, the patient dies from a fulminant infection, from a mistake we did as a team, as a healthcare system. This happens all the time. And so I'll get to the impact of it. And then there are problems with communication. How many times you've gotten you get a test done, you see a doctor, but then nobody calls you back? Again, it happens to me as well. And all of this is happening in a very, very busy context. COVID killed like a really, really big hammer on all clinicians, leading to a lot of burnout and shortage. And hospital systems aren't helping. They really want to hire the least amount of people. They want to have the least amount of beds open. So all this causing burnout, and thus this very significant shortage, which is only going to make things worse. Which is why there's an estimated, and this is a staggering number, if you can leave the room with this, 800,000, an estimated 800,000 people in the US. So one person in this room is either going to die or get disabled due to an error in the healthcare system. The death due to error is close to death from heart disease and cancer. 25% of patients that die or go to the intensive care unit in a hospital is because of a medical error. It's not a subtle problem, and we need to solve it, Jean-Claude. We do. So, there's always been an attempt at trying to solve it. The EHR, the electronic health record, was an attempt at doing it. But we've become cynical, Jean-Claude. Like we've had all this technology, we don't know how to fix it. But then, in December 2022, so I work in clinical reasoning, and I want to teach clinicians how to think. I want to also assess how they think, so that if they don't know how to think, they need to change their jobs. And then I got a hold of GPT. And then I started having a conversation with GPT, and I gave it a clinical case, and it responded to me in a way that was eerily concerning on how it sounded like a clinician. And this was GPT-3. And then GPT-4 came about, and things were a bit, made us really excited. And so we did a few studies, and for example, the study that we did with the group is we took some of these cases that we used to assess human doctors, and we gave it to a whole bunch of doctors from MGH and Beth Israel together, and we compared how they think through these cases to GPT-4, and GPT-4 thought better than these clinicians, with the same accuracy, same efficiency. And we're not the only ones seeing this. Google did a study, and this is a great study. They took patient actors, so they took people that are actors. They told them, okay, this is a disease, you're going to act that patient out. We're going to give you a chatbot, an iPad, where you're going to have a conversation with the iPad. You don't know who's behind the iPad. Either it's going to be an AI, or in this case, Google's AI, or a human clinician, and they were blinded. And so they had a conversation, and then afterwards, the patients assessed the interaction with the chatbot, and then clinicians assessed how the doctors were thinking. Universally, the chatbot was preferred by the patient, but the AI was preferred by the patient, and the AI did better than the clinician. So this is very exciting. And I do think that, back to your fantastic quote, I think there is something here that we haven't seen before. But Jean-Claude, how do we implement it? We've had so many opportunities before, and I'm afraid we're not going to take advantage. Like hospitals, like I said, I don't know how much they care about error, or do they?
Yeah. So actually, it's a good question.
Thank you.
So I'm not an MD, so I can only look at healthcare at the sort of macro level, because I can't look at it at the micro level. So at a macro level, what's happening in healthcare is cost of healthcare is $4.5 trillion in the US, 18% of GDP. I don't know if the outcomes are there, but the dollars are there. And the problem is that we have misaligned incentives, right? How does money get made in healthcare? When people get sick, right? You get sick, you make money. So money is made not when people are healthy. Money is made when people are sick. If everybody is healthy, the spend in healthcare would be $0. So So there's a trend that's happening that Center of Medicare and Medicaid Services is driving, has been expanding for the past decade or so, and is picking up steam, which is this concept of value-based care. Value-based care is a concept in how the finances of healthcare happen, where money flows and rewards happen when actually humans are healthy. They don't have to be patients. They just have to be people. And they stay healthy. They don't become patients. Or if they become patients, they get to the next best possible state as fast as possible with the least money spent as possible. So that's the idea of value-based care. I'm a big believer in that model. I think it's what's going to get us to not keep increasing that number while getting the outcomes that need to be gotten for ourselves, right? For our families. Everybody wants good healthcare. So then as we think about AI in healthcare, and more importantly, AI in value-based care, there are many utilizations for it. And they're not all, by the way, I think some of them are about tackling the shortage problem, right? Like, how do I use AI in a clinical setting at point of care? But AI can be used in a multitude of ways in healthcare to advance it towards this concept of value-based care. This is a framework that I created. So on how to think about the use of AI in this world of value-based care. One is as simple as making sense of data. So walk around, go to a hospital, go to another hospital, your insurance has claims on you, you have other information from therapy facility, whatever that is, that information is not aggregated, cannot be dissected, sliced up for anybody to get a full understanding of you as a person. So number one is applying AI, mega advantage to be able to make sense of data and bring all of your data together as a patient to make sense of what your current state is. Second one is detecting or predicting medical conditions. This is where you're going at, right? Which is using AI can sift through data way faster than a human. If you are in a hospital, I'm not an MD, so I'm going to say that. You tell me if I'm wrong. If you're in a hospital, in ICU, and a physician in the middle of the night at 3 a.m. is trying to see if a patient is septic or not, AI can make that decision way faster. Can predict whether a patient is going to become septic and drive interventions way earlier.
Yeah, I mean, it's known that if you happen to be sick and go to a hospital on a weekend or at night, the outcomes are lower. And it's partly related to staffing, but a lot of it is also related to fatigue and human error. If I'm called when I see a patient at 9 a.m. in the morning, when I start my rounds in the intensive care unit, I guarantee you I'm going to be in my tip-top shape, I'm going to have the best decision-making, I'm going to make the best decisions. If I see the same patient at 11 a.m. or closer to noon and I'm hungry and I'm done, and I'm going to defer a whole bunch of decisions, and that patient is going to get less care. And that's actually been shown, for example, in a tribunal. If a judge sees somebody going in front of them, they're much more likely to make a decision if they see that person at 8 a.m. rather than 11 p.m. So yes, if it's 2 a.m. in the morning and somebody calls me and I need to rush and I'm sort of like boggled-eyed and I need to start thinking, having that sort of assistant or that augmentation can really, really be helpful.
Yeah. Third vertical is this concept of augmented clinical intelligence. Is we as humans, the next best healthcare action that should happen on us is a knowable thing. It's just not knowable to humans, right? We're complex human beings. We have a whole bunch of conditions, and AI could be the perfect tool to get to advise on what should we do next to that patient. If I double click on that for a second, there's this conversation happening around, will AI replace doctors, and will patients only use AI, et cetera. The one thing I can tell you is that, and I can assert that, you can record it today and say Jean-Claude said that, is I don't know if AI will replace doctors, but doctors who won't use AI will be replaced. As we become knowledgeable, this audience is now probably knowledgeable after this conversation, on what AI can do, I believe that patients will refuse to be treated by doctors who don't use the utmost technology, including AI, to take care of them. So it's here to stay. It's going to be in healthcare. It's going to augment physician. The fourth area is autonomous interactions, right? You can use AI to interact with patients. Patients can start interacting with AI. I believe what's going to happen in that space is much like what happened in the cell phone industry, where rapid adoption did not occur in developed countries, sorry. Rapid adoption occurred like in Lebanon, right? We bypassed the whole infrastructure of telephony and moved straight to the mobile network. What's going to happen is, I believe AI's adoption will happen in places where there's extreme shortage of clinicians, and the delta between where people are and what AI can create is going to be huge. That's going to drive rapid adoption, even if AI is not perfect. So, with that in mind, AI could.
So, question for you.
Yeah.
I like that because my biggest concern is how can we, I grew up in Lebanon, and if there's 800,000 errors in the States, there's probably the same amount in Lebanon, but there's just, a much smaller number of people. So it's a problem all over, and so I'm really looking forward to having this solution shared equitably. And then, so I want to talk about guardrails for a second. So
yeah.
Can I have the clicker? Yeah. And so what I'm going to share with you are some risks of AI. We're both very excited. I think it's going to happen. And it's just about how we implement it. So Jean-Claude, it's all on you. And then, so this is a little bit the image that we are hoping for. A clinician here that's talking to a patient, and AI on the side. We don't need to spend our time on the keyboard anymore. There's a scribe, it's taking it in, creating a note, summarizing it, really doing all of the help. On the right here is a simulation for education. The impact on education, this is like a completely different conversation and maybe even a different conference, but it's very significant. I'm going to show you images on bias, and I want to preface it by saying these are real images obtained from AI and that reflect error and reflect bias. This is not meant to be political at all. I was shocked when this happened, and then so I'm just going to share it with you. So this is actually shown in the Washington Post. So an AI was asked to create images, and so when it was asked to create images of attractive people, all of the images it obtained were of young and light-skinned. I'm not going to comment. I'm just going to let you guys sink in. I'm not going to be sort of bias you. On the left here, you're going to see when it was asked to draw persons working at social services. They're all people of color, and they look tired. They seem to be working in poor settings. And on the right, asked about the productive person, they're all male, and they're all mostly white. And they're all a CEO type as opposed to a doctor, which is annoying. And then cleaning. Yeah. So this is Washington. This was published in the Washington Post. This is old. I think whatever tool was used to do that was certainly updated. And then, so one day I was preparing a medical grand rounds, and one thing we did is I engaged the audience in a clinical case. So I give a case to the audience, and I give a case to GPT-4, and I see how it does. And I asked it to prepare, to draw a, so I said, this is a prompt, so prompt engineering is essential, and having subject matter expert. I'm preparing a medical grand rounds where I pit a human against GPT to make a diagnosis for a case. Create a drawing using the style of 1950s comic book, and it drew this. It's beautiful. If you've read any comics from that area, not that I have, but this is how it looks like. It's really nice that you can see even the granularity of the image, really beautiful image. And then in homage to a Palestinian doctor that I know, I asked it, this is wonderful, now do the same with a Palestinian woman. And then it gave me this. So just to let this sink in, and what's interesting is that depending on the audience and the crowd, and when I show this, some people may not see anything wrong with it. But from my perspective, I did see a fair amount of bias here. And again, I preface this that I'm seeing this from my personal, social, and cultural lens. Others may see this differently. The fact that she's veiled, she looks very threatening. There's this like explosion aura and fire around her. There's a scared, you can see in the background, there's a scared white male, like it's a scared doctor in the background. There's a very relaxed Jordanian male doctor. I say Jordanian because of the kufi, and my wife is Jordanian. I have no idea what's going on with the patient, but it doesn't look very happy. So that's what we're dealing with. And so we're very excited, Jean-Claude, but we really need to be careful.
The assumption we have is that AI is going to continue its path of growth. It requires extreme computation, right? So I don't know if you noticed that chart. The bottom of the chart was how much training was put in the models. So the models were trained with more computational power. And it's not that they got better. People didn't write better code. I mean, they probably wrote better code. But the primary evolution is that they got trained with more computational power. With more computational capabilities, like quantum computing, that is going to be yet another avenue for AI development to accelerate. I mean, that's how I would link up the two.
Are people using AI before you fix out all the kinks? And if they're not, then how long do you think it will take before they fix all the problems?
Great question.
Okay, do you want to take that?
Yeah, I mean, that's actually a fantastic question because it's already being used, even though it hasn't been tested. Like, the same way that doctors use Google, and Google's not certified to be, Google.com, that's not certified for medical use. People are using AI and GPT-4 in particular to help them in making diagnosis and taking care of patients. So in fact, yes, it is being used and it is a big problem, and which is why your dad needs to work quickly to implement safely a GPT-4 in the healthcare system. What AI does is find patterns where humans can't find patterns quickly enough, right? So we do research, it takes us 100 years to find a specific, and to answer a hypothesis, it can take AI a day. And so the computing part is very fast. So it's helping in all aspects of drug development. We're starting from finding a target for a particular disease, finding a molecule that could address that target, even simulate patients. That's actually pretty cool, where they can use AI to simulate patients of different properties and then test virtually in simulation if a particular drug could work on the patient, so on and so forth. So there's a dramatic impact on drug development. Yeah, so New York Times is suing OpenAI, right, because it's using its data. I work at the New England Journal. We don't allow, unless they pay us, we don't allow them to use the data. And the New York Times just published a piece where OpenAI and Google both knew they were breaching copyright and have actually stolen information. So regulation needs to happen. That's going to prevent them from using it without sort of paying proper due to the authors. But it's a big problem.
Let me just add to that. There's also, I believe it's a paradigm shift. If we think about AI as an aggregator of copyrighted content, then I think this issue applies. I think if we shift the paradigm and we don't think of it as that, and we think of it as creating an entity that can reason and think and participate with us as humans to create a better world, then it's no different than us as humans learning from thousands and thousands of books ever written that and all of the knowledge that has been accumulated by humanity. We benefit from it, right? My children wake up now and they benefit from all of the knowledge of humanity, and without a worry of whether they literally have bought every single book and paid for it that was ever created for them to accumulate that knowledge, they benefit from it. And that's a paradigm shift, right? That's no longer a software that has accumulated this knowledge and copyrighted knowledge. So I think it requires a paradigm shift. I think it's probably unstoppable. We're on the other side of that. The question is, how do we regulate it to be okay? I don't think we're going to unwind it and remove content from GPT.
We're going to take one final question. Go ahead.
Yes, I'm a physician myself. My name is Tony Tenori. So I had a question about the plagiarism and the royalty and copyrights for events. And my concern with the AI, and I agree with you, that physicians have to work with the AI, otherwise it will become obsolete. I'm on board with you. My concern is the following. The AI, it's going to kill innovation. It's got to create innovation somewhere. So it's the only reason I can write a paper or I can write an article, because I have to come up with my own ideas, and then you get royalties or you get notoriety somewhere. When somebody's got to take that same information, just like going into a subscribed journal versus open journal, right? it's going to kill innovation. Because why would I innovate that somebody else is going to come and take it very easily? Why would I go, work and create an algorithm with the whatever, like whether it's a medical or fintech or industrial, and then somebody else going to come and get it free the next day.
Yeah.
So that's going to definitely, that's the next phase where we're going to see, actually innovation is, because we talk generative AI is by definition generative. It's basically regurgitated information. They're not creating new information. You're regurgitating the same information.
So I'll take that very quickly. So there's a quote that I'm gonna butcher completely, so I apologize for that. And so it goes something like this: like this invention is going to make humans not be creative and create new content, but only repeat content that was already created without applying critical thinking to it. And that quote was by Plato, talking about books, when books were created. And books were regarded like that. When books were first brought up, people were like, wait a minute, people are gonna write books. All the other people have to do is open a book and repeat what's in it, so where's the creativity? And that didn't occur. So I truly believe, a personal opinion, so it's, that nothing has stopped human innovation, right? So we still are creating AI. We will create tools on top of AI. The innovations that are needed are not, if AI can do the work, we should do the next job, right? So that's what we've always done as humans, right? When any technology, not just AI, right? Any technology has done what we do, we find the next thing to do. And there are so many things to do in the world to get it to a better state that I think our work is cut out for us. So I'm excited. Raja, I don't know how you feel.
Yeah, so just a quick thing. So as an example, I'm writing right now a review article on AI in education. And I'm, something that Richard said earlier, it's difficult for me to start anew. And so I've been having these conversations with ChatGPT, and where I give it thoughts and I give it context that it's never been trained on doing. Right? It's not trained on the content I'm giving it. And through conversations, it's actually helping me if it's not it doing it. And I don't create ideas and create something new that's intellectual. Now that's on one hand. On the second hand, there's a risk of de-skilling, meaning if the reason I can reason through a case is because as a resident, I had to write my notes. And as I write my notes, it helps me think and helps me build my structure. I have a problem. I think there's a risk of de-skilling. In terms of plagiarism, I completely agree. I think the big risk is that AI sort of crawls through all our work without us knowing, takes it and makes it its own. And I think that's what's going on. It's a big legal battle. It's a big copyright battle, and I think it's a true one. There are tweaks that we can work around right now, but I think it's not very safe. But it's a risk that definitely needs to be addressed.
All right, obviously a very interesting and charged conversation. Let's give another round of applause for Dr. Raja, Elie, Abdulnour, and Jean-Claude Saghbini.
Good to see you.
Thank you so much, gentlemen.